Hello, everyone. I am here with the famous Dr. Katz from Katz Chiropractic, and we are talking about our favorite topic in the world, craniocervical instability. And today we're going to talk about the research that Dr. Katz has been doing with craniocervical instability. But first, thank you so much, Dr. Katz, for hanging out with us today.
Well, thanks so much for having me. I really appreciate it.
So can you tell me a little bit about your practice and more about yourself?
Yeah, sure. So our practice, it's my wife and I, Dr. Shauna, who I know you've met as well. And we've been practicing in Boulder, Colorado for almost 20 years. And during that 20-year time, about 18 years ago, we purchased a digital motion X-ray. And that kind of opened the can of worms of, wow, we're seeing all sorts of stuff that we know is a problem. And then the $1 million question is, how do we fix it? And a lot of that was the craniocervical instability. Like it seems like at least from what I've seen, it seems like patients are starting to become more aware of it. But we've been talking about this with Dr. Centeno or Regenix for 18 years. Like, Dr. Centeno and myself have worked together looking at these for 18 years. So like, oh my gosh, this is an issue. And what do we do? Because so many patients will run into providers that aren't aware of it, or they look at it and they don't know what it means or what to do with it. So it's been a progression of trying to get information out there to other providers and patients. So in our office, we really look at the full biomechanics, not just the upper cervical, but the shape of the spine. There's a lot of problems if you lose the normal, what's called sagittal alignment or shape from the side. And then also the other segments that could be not moving well that can affect other areas as well.
So can you tell me a little bit about how this research project came to be? What started it, and what did you learn, and what were you trying to research?
Yeah, so this was about 8 years in the making, probably a little bit more. And I'll try to keep it narrow so it's entertaining to a degree. A lot of things, we see a lot of patients that are hurt, and we see a lot of problems and pathologies. And a lot of these patients would come back, either they're providers, or if it was like a trauma case, because we see patients in crashes, that crashes have really documented that a lot of these injuries occur in traumas as well. But the insurance companies and providers would be like, it's no big deal. How do you know that's a problem? And there's a lot of evidence to show that it is a problem. But the big question was, well, how often do we see this in asymptomatic individuals? So Dr. Centeno, myself, Dr. Michael Freeman, who he is the nation's leading forensic epidemiologist. He's, the guy's a master in public health. He's a chiropractor. He's an MD, a PhD. Like he's just
Smart dude.
Oh my gosh, a forensic epidemiologist. And he said, we need to do this. We really need to see, like, let's get a large sample to see how much is this common in the asymptomatic population. And we started to do it. And it was a lot. It took a lot of time. And that's why we had radiologists on it. The reason it took so much time is to really read one DMX. It could take, let's say, 10 minutes, right? Really sitting down, measuring it. And we did 196 of them. And I think we read them each 4 times.
A lot of minutes.
And we had 37 parameters on each one. So basically 37 parameters times 196 times 4. And then we would cross-reference it and we read them blindly. So we didn't know if that was the injured person or not. And we wanted to see how common is upper cervical instability compared to normal population. It's never been done. In fact, instability in itself from C2, C3, 4, 5, 6, 7, we know is a problem, but no one has known, like, is there a percentage difference between injured and non-injured through a full range of motion. So we didn't want to just do a flexion extension view. We want to do a full DMX view, because one of the things that we've seen also that I think, and I hate to say this, that I don't think it's totally appropriate for docs to do to patients, is they'll do the open mouth lateral bending in a static view. And what we've seen is you can miss, let's say 2 millimeters. And 2 millimeters, as you know, it's really hard to get your mouth in that perfect position. And if you see a slippage from here on a regular x-ray, but then the difference is here, that extra millimeter or two can be a gigantic difference, both clinically and on a follow-up. So we were just like, let's do this. So we spent, it was 8 years. And the reason it took 8 years was, we have a full-time practice, Freeman, all the other people, it was really hard to get all of our schedules. And then finally the last year and a half, we're like, look, we're 80% done. We just need to sit down. And we would get up 3 in the morning. My wife, Dr. Shauna, would come in and she'd see me like sitting like this. And I wouldn't have to say anything. She's like, you got a call from Freeman, huh? And I'm like, I need to read like 30 more of these and go through it and put arrows. And it was killing me. But, what's fascinating is just like patients know, like, something is wrong.
Right.
But we didn't have the data to say, this is wrong 17 times more than in the asymptomatic group. So it was easy for patients to get brushed off and say, well, my provider doesn't think that's a big deal. Oh, he thinks that could be normal. And we knew that it's abnormal, but we didn't know by how much. And I got to be honest, we've read in the last 18 years, like thousands and, probably tens of thousands of DMXs, of studies. And we knew that it's a problem. But even if you asked me, well, how often do you see it in asymptomatic individuals? We couldn't answer that.
Right.
Right. So we started, and I'll be the first to admit it. This is going to sound terrible and come back and bite me in the butt. I was like, it's a really expensive machine. Like, what if we do this? And it shows that these patients, that they're no different.
Right.
And Michael Freeman looked me dead in the eyes. He's like, well, don't you want to know that for your patients? And I was like, I do. Yeah. So let's do it. And I did not, to be honest, even with how much we know craniocervical instability is a real problem, I did not expect to see that much of a difference between injured and non-injured.
And so what did you see? What did you learn?
Gosh, if I switch over, will it ruin the camera? Like, does that mess anything up?
If you share your screen?
Like right now, can you see me just fine?
Yeah.
Oh, okay, because I just switched something. So what we found was a couple of things. And then we have another finding that, because we tried to do everything, but we found another finding that wasn't published, but it is gigantic. And I'll read to you what all that is. So what we found, if we just look at, let's say the upper cervical spine, we found that, hold on one second. We look at C1, C2 overhang, and we looked at a couple things. One, we used to think that 2.2 millimeters was unstable. And we actually found that that's not true. We think it's more, we pushed it to 4 millimeters, and really 3, there was a big problem. 4 was a huge problem. So we wanted to see, okay, well, what's the gigantic difference? So what we found was that C1, C2 lateral overhang, we found in the symptomatic population about, around 65% of the time, and only 30% in the asymptomatic individuals. But when you couple that with the periodontal space, we found up to about 30% of the symptomatic population had it, and only 3.9% of the asymptomatic. Now, the other thing that we found, which is really crazy, is that there was about 32% of the uninjured that had a little over 2 millimeters of overhang, but none of that same group had an abnormal periodontal space, right? So we never saw over 2 millimeters overhang and a periodontal space in the asymptomatic population. So that accounted, there were only 3 out of 77 who had a normal overhang with abnormal periodontal space at 4%. However, in comparison, among the injured patients, there were 28 with both abnormal overhang and periodontal space, and there were another 47 with abnormal overhang and no abnormality of a periodontal space. So what that means is the positive predictive value of the joint finding for identifying injured patients is 100%, which is the probability that a positive finding means that the patient is injured, and we had 0 false positive rates.
Wow.
Yeah, which is like we were like, I don't even know how that's possible. Sorry, I lost the camera, so I'm gonna try to find where it is. Hold on. And that's just looking at, there we go. And that's just looking at just the C1, C2 lateral overhang and that periodontal space. So we know comparing it to a large non-injured group, it's not found. It's very rarely found, and it's commonly found in injured patients, especially after trauma.
And previously, there was no definitive diagnostic tool for craniocervical instability, right? And no great one, at least.
No, so I was talking to someone on one of these forums, and he got a little upset with me because he's like, well, you didn't look at grab oaks and you didn't look at CSF flow and brainstem. I'm like, that's not instability. Those are signs that there's a problem. And a lot of times, like a static MRI is great, and it can show that the ligaments are disrupted, but it's not showing if it's moving, right? So I sometimes will have a DMX and we'll send for an upright MRI. Why? Because the DMX could have a lot of instability. The upright MRI, you can see if the brainstem is hanging down, and you can see if the cord is being compressed through with, grab oaks. So there's a misconception of, is this unstable? And I see a lot of people post static images and they're like, do I have instability? And it's like, you have signs that there's some chronic instability, but we don't have measurements of instability yet, right? That's like someone, in a sense, like, okay, I hurt my knee, and you're just looking at it and you're like, a football player, and you're like, I think it's unstable compared to someone doing this.
Right.
So there wasn't a lot until, the digital motion X-ray and really moving to see what is happening. And that's the other thing we looked at in the study was we didn't just look at how the bone at A and Z. We looked at how does the bone get from A to Z. And we also found in other areas of the spine that abnormal coupling patterns. So you see true abnormalities in the mid phase that if you don't have a movie of the spine, you miss it.
Right.
And that's some stuff that we've seen as well, which is really fascinating and we didn't write this up, but let's say this is C1. We've seen some really weird stuff with C1 where, it tilts and then at the very last second it drops and you're like, whoa, and you would miss that without movement. Or we've seen others where it, if we're looking at it from the side, and I'll send you some amazing, that maybe we could try to add into here, where you see C1 and during the mid ratings it pops. You would never, and it's super bizarre. And we're like, whoa. So you couldn't see that in static views. And I have some really great, samples of that I can send you.
So
I'll bring it up.
So what do you think this research means as a whole for the instability patient population?
Well, I'd like to think that it means they have some validation that they're not crazy, and we've had so many patients literally cry after their DMX because for a decade they were told that they're crazy, that their pain is all in their head. And then we see this like significant instability. And I always joke, even though it's not a laughing matter, like it is in your head. That's where the pain centers are. You're feeling it in your head because you have you're unstable. So I'd like to think that some docs are going to really start to look at this. Like this is the research right now. It's kind of the gold standard. It's one of the largest biomechanical tests between injured and non-injured, right? Not just like, oh, look, we did this on injured patients and a lot of them have it, but then it's like, well, is that also common in uninjured population? So I'd like to think that these patients can take this paper and say, it was in a really good peer-reviewed journal with a really good impact factor, great science that was done around it, more than what I even know, because that was all the PhDs on how they looked at it. And I'd like to think that these patients can start to advocate for themselves and can say, hey, doc, you said that this doesn't mean anything, and that's your opinion, and that's great, but here's some scientific data to explain that there's something wrong, and I want to know if you can help me, and if you can't, can you get me to someone that understands this?
Absolutely. So I'm curious, you mentioned that not all of the patients who had symptoms for craniocervical instability also had overhang on the DMX. Is that correct? So what are your thoughts on that?
Well, so we did it on like neck pain and trauma. So the question is, not everyone who has neck pain has upper cervical instability. So that makes sense, right? We did a study on patients that have had neck pain and headaches of 6 weeks or more. So some of those patients that had neck pain, they don't have upper cervical instability, but they had other issues, right? So if we look at the other areas, for instance, I'll switch over. So like, for instance, here's a huge one. Let's see, facet gapping here, right? So at C5, C6 facet gapping, 37.9% of the injured patients, and facets can really be a pain generator, 37.9% of those patients had facet gapping at 5, 6, and 0 of the asymptomatic individuals had it. And at 4, 5, 34.5% of the symptomatic group had it, only 3.9% had it in the non-injured group. So a gigantic discrepancy. So what I think about that is, we did it as looking at the neck, and not every patient has upper cervical instability. That, if you have neck pain, there's a lot of reasons for neck pain. It's not always about upper cervical instability. But what we did find is that pretty much no asymptomatic individual had upper cervical instability, if that makes sense.
Mm-hmm. Absolutely. So it's great as a confirming tool.
Literally, if you're having pain symptoms, let's say, especially if you have, something that brought it on, I was in a crash, my head was turned. There's a lot of evidence and research that shows that, head turn trauma damages the upper cervical spine. Like, that's been published many times. And if you have all those things, and then you're like, you have the signs and symptoms, you have a clinical exam that correlates, and then you do upper cervical instability. One, you're like, all that correlates. And two, this finding is barely found in the asymptomatic group, and you're not the asymptomatic group, and it's commonly found in the injured group.
Mm-hmm.
Come up with an appropriate diagnosis.
Yep. Yeah. I mean, everything you're saying about how patients were repeatedly told they were crazy or thought they were crazy, that was exactly my case. And I actually, after my injury, I went to an attorney to try to sue the person who damaged me. And he looked me in the eye, he said, "I'm not telling you I don't believe you." He said, "But I don't have a test to be able to prove your case in court at all." And now, if this was a few years ago, I might have been able to have a case and be able to help pay for literally the tens of thousands of dollars that I had to spend between Regenex and massage and everything. This patient population has just gone through a lot, and if they don't spend a lot of money, they spend a lot of pain and time with a spine fusion, which is terrible.
Oh, which is which is really terrible. I just did a webinar with a neurosurgeon here about a lot of different topics, but one of the topics was upper cervical instability, and I can send you a link to where it is. And he basically is like, he's one of the main neurosurgeons of, I think, the 5 hospitals here in town. He's like, I don't fuse C1, C2 unless all else consistently fails, because once you do that, he's like,
no going back.
There's no going back. Like, you can't divorce that. And he also knows like what that does, right? And I think that's the other interesting piece of all this is, you don't just have instability, right? You have disruption to the mechanoreceptors, to the proprioceptors,
Whole spine.
The whole spine. And then if you fuse it, you no longer have input of mechanoreceptors and proprioceptors. So it's and I think that's the frustrating part too, is me trying to help these. And I'm not going to speak for Dr. Centeno, but we're doing our best. And, there's some people like, I tried it and it didn't work. It's like, nothing is 100% of the time. We're just trying to do the best we can. And it's tricky. You're trying to stabilize something that's a very movable joint. It's really with a lot of moving pieces, and when it's damaged, it's, and I feel for these patients, like, we've seen the good, the bad, and the ugly. We've seen the patients that have been struggling like you, and then we treat them and they get their lives back. We've seen others that like, I know what it is. treatment helped a little bit. And I'm managing it the best I can. And then we've seen the ones who have had to have the full fusions, and we've seen the good and the bad of that too, you know, where the fusion seems to do pretty good. And then we've known some patients that were in so much pain afterwards, they were in really bad shape. And it's like, we're all like, and there's no slam on the surgery. They're trying to do their best too. It's unstable. We're going to stabilize it.
Yeah, absolutely. So I know when you're writing a research paper, your hands are sort of tied where you've got to stick with the facts and the case that you're trying to test, right? But there's probably a lot of things that you might have wanted to put in the paper, but you didn't. Maybe it's because you didn't have enough evidence or data to draw a conclusion, or just something interesting that came up. Are there any stories like that, or anything that you kind of wish you could talk about, but or maybe you can't be 100% about something, but you have a personal takeaway that you'd be willing to share?
Yeah, I mean, I published a couple of papers. I published one way back I think in 2007 with Dr. Centeno, and I'm not a researcher. My wife and I aren't. We just see really
You are
cool.
now.
What's that?
You are now.
And we see cool things, and we just always want to learn. We did one recently, and we were the first authors where we published a paper in the Journal of Brain Circulation where we show that an abnormal neck curve decreases blood flow to the brain. And we did that on pre and post images with angiograms. And I don't know how to write these up. So we get the data, I'm like, here's their pre and post images, here's their notes, here's what I know. And we hire a PhD. And with this, it's very like, what I would have liked to have done is maybe, which I guess we always could do, is to break down the percentage of patients that had upper cervical and look at their symptoms, right? Did it as neck pain, headache symptoms. They were heard. And we took 196 patients that fit this category, and we excluded ones based on their age, and then we took asymptomatic individuals. I would have loved to have seen like, all right, of these X percentage of upper cervical instability, do they have pretty common symptomatology? And that it would be, because we have the data and know that they do. We just couldn't publish all that, because then we would have to also add in the 37 parameters for all the others, and it would have looked like a dictionary, you know. I'd have liked to have done that, or I'd like to go back and take this data and see if we can extrapolate other details of like, where is their pain pattern? Are you dizzy? Do you get headaches? Do you get lightheaded? Like the things that a lot of upper cervical instability patients suffer with. And then say, oh my gosh. And maybe what we find is like, wow, of the X amount of patients with upper cervical instability, 96% had these four commons associated with it. That would be fascinating to know.
Absolutely. Absolutely. And then more research could leap off of that by combining DMX results with certain symptoms. So for example, maybe a certain overhang or a certain vertebra or something else will correspond, because I can tell you I've had so many conversations with other patients, and it is all over the place. Everything from swallowing problems to vertigo to facial pain to neck pain to muscle tightness, everything, anything nerve related or that could be handled by the vagus nerve. It's all over the place.
It's all over the place. And the other thing too with that I see in these forums and with our own patients is, and I hope patients don't get mad at me for saying this, but in the forums, like, I have these symptoms. Do I have upper cervical instability? And
right.
A lot of stuff that I see on the images that are like, you don't have upper cervical instability, but you have these pathologies, and that can also cause these. And that's the hard part too, is there's a lot of things that can cause a lot of symptoms, and we want to try to address them all. It's not always just C1 or not always just C5. It's like, how does it all work together? And that's the paper that we just submitted in for publication that we looked at on what have we done to stabilize upper cervical instability. And we've seen it. We've seen hundreds of them. We took, multiple patients. Wasn't a huge sample size. I was like, hey, let's write these up. Here's some patients. And we actually excluded a lot after this other paper was just done, because we're like, oh, let's just get rid of anyone under 4 millimeters. So we took even the 3.5 millimeters, where like we excluded them again. We're like, let's just do the 4 millimeters. And we took some of those from 4 millimeters down to like 1.5 or 2. And we actually fixed that without even really, quote unquote, touching C1. We just looked at the sagittal alignment of their spine and the stability below it, because you can't have a stable upper cervical spine if below it is unstable and out of position. You're just going to constantly load the ligaments.
Absolutely. Well, I don't want to take up your whole evening. Do you have any parting thoughts or comments over the research, or anything else you want to add?
I mean, I'm incredibly happy and proud with what it showed, and I'm glad that our name is on it, and I hope, from what I've heard, it's helping a lot of patients, and I'm glad I did it. I'm glad I took a couple of years off our lives, or got some balding on top of my head, because I think because I think from what we've seen for the last 18 to 20 years, patients with upper cervical instability are so mistreated. They're pushed to the side. You're crazy. Get out of here. I just did a laying down MRI. I see nothing. Get out of here. You're drug seeking. You're trying to get disability. There's nothing wrong with you.
Totally.
And to see this, to say, whoa, you can't say that anymore unless you rule it out appropriately. And you can't say it anymore if they have these findings, because we compared it to the uninjured population, and you can't fake that. Like, you can't fake that abnormal movement. It's impossible. So that, for me, when I'm treating a patient, I know that you have this. And I don't care, I've gone to court talking about these injuries well over 20 times for patients. Like, this is what it is. I don't care if some doc says my opinion is this. I don't care what your opinion is anymore. This is what we know. And these patients really need, just like they needed something to come out to step up to get them the care they need and the treatment they need.
Absolutely. Well, thank you for all of the contributions that you've made to this field of research, because we're kind of an underserved population, because we're the wacky redheaded stepchild in terms of symptomology and everything else. So for listeners who are interested in reaching out, potentially getting a DMX scan, what would be the best way for them to contact your practice to start the process?
They could just, they just call. The number's 303-938-9070, and it's Katz Chiropractic and Rehabilitation Clinic in Boulder. And we do the evaluations, we can do the DMX, we can help with treatment, trying to find them the right person. That's the best way, because the great thing is, especially with Regenix, they really, over the years, and especially with this paper, we do a really good job with our DMXs. They're super clear, and we've seen some that I know Regenix gets mad at, like, hey, the patient had a DMX and it's horrible.
Mm-hmm.
So, we're here for anyone that wants our help, and anything that we can do to get them this information. And then hopefully, if they're not here, they can get this information to their providers of where they are, that hopefully will take the time to look at and read this. But that's a whole other topic too.
Absolutely. Absolutely. Yeah.
I mean,
Well, thank you so much for meeting with me this evening, and I'm looking forward to our next video in the series.
Yeah, me too. I look forward to it. Thanks so much. I appreciate it. We'll talk soon.
Sounds good.